Welcome, everyone. My name is Dr. Raj Rasasingam, and I am the CPPD Director for the Department of Psychiatry at the University of Toronto. I really want to welcome everyone today to our Oxford Collaborative Grand Rounds, the citywide psychiatry Grand Rounds today. Before we begin, I would like to start with our land acknowledgement. I would like to begin with acknowledgement of the land that we work, study, and live. Before I read it, I want you to take a moment to situate yourself and think about the land under and around you. We recognize that many Indigenous nations have long-standing relationships with the territories upon which the sites of Department of Psychiatry are located that precede the establishment of the University of Toronto. We acknowledge our presence on the territories of many Indigenous nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa and the Haudenosaunee, and the Wendat people. Today, this land is home to many diverse First Nations, Inuit, and Métis people. We are very grateful to have the opportunity to live, work, and gather on these territories. We acknowledge that Toronto is covered by Treaty 13, signed with the Mississaugas of the Credit, and the Williams Treaty, signed with the multiple Mississauga and Chippewa bands. Since this event is a virtual gathering, a singular land acknowledgement does not capture the richness of our distribution across many locations. There are few places on earth that someone before us has not called home. So thank you, everyone. And I'm just going to briefly go over some housekeeping items. Evaluation link will be sent to the attendees after today's presentation. Any feedback is always appreciated. And we thank Dr. Catherine Harmer and Oxford University with respect to this collaboration. I'm going to stop sharing at this point, and I am going to welcome Dr. Benoit Monsant, the chair of our department, to do the formal welcome. Dr. Monsant, go ahead.
So thank you, Dr. Rasasingam, for your introductory comment. And I want to thank also all the audience for joining us today for the annual Paul Garfinkel Lecture and our citywide rounds of February. Today's lecture is a manifestation of the collaboration among our department, the University of Oxford, Oxford Health NIH Foundation Trust, and the Center for Addiction and Mental Health. These four organizations are committed to work together to accelerate innovation in psychiatric education and research with the final aim of providing better care to patients with severe mental illness. Today, we have an opportunity to learn from our colleagues at Oxford, and I would like now to introduce Dr. Vicky Stergiopoulos, Vice Chair, Clinical Program and Innovation in our department, who will introduce our speaker.
Thanks, Benoit. And I would like to, it's my pleasure to introduce Dr. Catherine Harmer, who is going to talk to us today about how do antidepressants work. Catherine trained in experimental psychology and subsequently psychopharmacology at the University of York. She came to the Department of Psychiatry at the University of Oxford in 1998 as a postdoctoral research fellow, and was appointed as a professor of cognitive neuroscience in 2007. Her work focuses on the cognitive mechanisms and underlying treatment effects in psychiatry, using a combination of functional neuroimaging, cognitive measures, and psychopharmacological challenge tests. Her work is funded by the Medical Research Council, the Wellcome Trust, and the NIHR Oxford Health Biomedical Research Center. And she holds a number of distinguished positions, including serving on the executive committee of the European College of Neuropsychopharmacology, being an associate editor for psychological medicine, and a council member for the British Neuroscience Association. With that, up next, Catherine, it's your turn.
Thank you very much indeed. I will just share my slides. So hopefully that is all looking fine from your perspective. Let me know if not, but thank you very much for the invitation and the introduction. It really is a great pleasure to have this opportunity to connect with you all today, spanning the Atlantic between Oxford and Toronto. So I'm really looking forward to discussing this work with you and discussing collaborative opportunities going forward. So I'm going to be talking about antidepressant drug action, which is the main focus of my research, in particular looking at how the pharmacological effects of antidepressants may actually get translated into their clinical and psychological effects in depression and the symptoms and experiences. I'll also consider whether this kind of approach could help us to bridge the gap between how we understand and use psychological and pharmacological treatments. And I'll touch on some of the clinical applications and implications of this work as well, including some of our first attempts to translate what we've done in the lab direct into the clinic. So this is a long-standing question, of course, in antidepressant drug research. I remember reading this question as an undergraduate in my textbooks. Why do antidepressants typically take so long to work? And this is, of course, a problem for patients and for clinicians. It slows down finding the right treatment for each individual, as we need to wait for a period of time to see if that person is going to respond to a particular treatment and before subsequent adjustments can be made. But it's also a problem for our science, as we don't really understand what happens during this delay to mediate these clinical changes. And I think it's understandable that research has typically focused on changes which are also expressed with a delay in the brain. But I think this rests on a very important assumption, and that is that once you have the brain change, this will lead immediately to the mood improvement, that there's a direct relationship between the underlying neural substrate and the mood improvement. And this is one of the assumptions in the field that I would like to challenge today, using evidence that antidepressants are actually having quite a lot of really interesting effects right from the start of treatment, even though they may not be consciously accessible by the individual taking the treatment right away. So I started off as an experimental psychologist, and when I moved into this field, I was immediately struck by the apparent division between research and practice on pharmacological and psychological interventions. Now, this is, of course, an oversimplification in the diagram, but I think it's fair to say that most research looking at antidepressant drug action has tended to focus at this level of analysis on neurochemistry, cellular, molecular mechanisms in the brain. And researchers doing this research often don't have the opportunity to connect and meet and discuss with individuals doing the psychological therapy research, typically focused on a different level of analysis on challenging thoughts, beliefs, how we deal with emotion. I think there are differences between how these different types of interventions tend to be practiced, and also from the public perception, these kinds of approaches are often viewed as completely in competition with one another. You either believe in drugs or you believe in psychological explanations and treatments. And so I became really fascinated about how antidepressants and the kinds of processes that we see here on the left may actually affect what we see on the right, typically the remit of clinical and cognitive psychologists, thoughts, beliefs, and how we deal with emotion. And so this set the scene for what would become rather a long-running series of studies in my career, looking at the effects of antidepressants on core psychological processes which are relevant to depression, such as this so-called negative affective bias. So this is, in colloquial terms, referred to as seeing the glass as half empty as opposed to half full. It describes a skew or a negative skew in how information and emotional information around you is being dealt with. And it can actually affect all stages of cognitive processing, from what we attend to in the first place, how we interpret this information, and then what we remember later. And then this has the potential to affect how we feel, think, and behave. And I'm going to show you a really short clip taken from a video that we co-produced with young people with depression, describing this kind of negative bias in an everyday kind of situation, and also touching on the effects of antidepressants that I'm going to go through today.
You're walking along the street and a friend walks past without saying hello. If you're suffering from depression, you might think the worst. But antidepressants work by helping you think about alternative interpretations and changing how you deal with stress?
So this is a very everyday example. It's the kind of thing that could happen without you really thinking too much about it. The way we interpret these very ambiguous situations and stresses can happen rather automatically without us being aware of alternative explanations. But this kind of more negative bias in interpretation can affect how we feel, think, and behave, and reinforce some of the symptoms of depression. And so this negative affective bias has emerged as a key psychological factor in the maintenance of depression. It's an explicit target of psychological interventions such as cognitive behavioural therapy. But it also turns out that this negative affective bias is affected by antidepressant drug treatment. And perhaps the most surprising thing about these observations is just how quickly these effects come about. They can be seen within hours at the very first dose of an antidepressant, well before we would see any clinical effect of these antidepressants. And so this led us to propose this cognitive neuropsychological model of antidepressant drug action, which suggests that, as we know, antidepressants don't immediately and directly lead to improved mood and the symptoms of depression, but they may work via changes in emotional bias by increasing the relative processing of positive emotional information. This could set the scene for later clinical improvement through interactions with the environment and stress and difficult situations. So interpreting or dealing with this in a more positive way over time would be expected to lead to mood recovery. And I think one of the most important aspects of this is that the delay in this model then is not because of the need to adjust changes in neural function or in the cellular or molecular makeup of the brain, but rather the delay comes by the need for a period of learning or exposure to everyday situations in the face of this different way of processing emotional information. So the delay has a psychological element to it as well. And so today I'm going to go through some of the evidence for this idea that antidepressants can have very early effects on emotional information, that these early effects are related to later clinical changes in mood, and also that we may be able to use these kinds of early changes as a marker of non-response, which could allow us to cut the time taken to find the right treatment for each individual with depression. So going back to the beginning then, this was one of the first studies where we looked at the effects of antidepressants on emotional processing in depressed patients. Here we looked at the effect of just a single dose of an antidepressant, reboxetine, a noradrenergic reuptake inhibitor. We know that a single dose of an antidepressant is not enough to change symptoms or experiences in depression, but we wondered whether it would be enough to start to change how emotional information was being processed. And so to look at this, to capture the effects on these negative biases, we used a number of computerized tests. These negative biases are not always consciously accessible, so it might not be enough just to record them in a questionnaire. We need to look at dynamic response to different emotional stimuli. And so we know that when people are depressed, they find it harder to recognize these kinds of positive or happy facial expressions of emotion. We use a task where we have these different morphed intensity levels. They're put together here in an animation, but in the real task, they're all mixed up with other facial expressions of different intensities. And so you can see here that when it's a full beam like that, everyone could definitely recognize it, but there is a level of ambiguity just as the smile is starting, where it could be subject to differences in interpretation. And that's exactly what we saw here in the study. First of all, looking at the comparison between depressed patients and healthy controls. This is the recognition of happy facial expressions, the accuracy. And you can see that, as in previous reports, when people are depressed, they find it harder to pick up on these positive affiliative facial expressions, the so-called negative bias. But in the lower graph, what you can see is what happens with just one dose of an antidepressant here compared to placebo. And you can see that recognition of these happy faces has increased. These patients don't feel any happier. They're not less depressed after this one dose of an antidepressant, but you can see in terms of information processing, they're already more receptive to this kind of positive affective cue. And we can see very similar effects in other tasks measuring different aspects of emotional processing. So for example, emotional memory. Here we present these kinds of positive or negative adjectives, which are very clearly positive or negative in the context of one task, and then we ask people to remember them later. But when people are depressed, they find this task, the memory task, more difficult, and particularly trying to remember the positive words like cheerful or poised. You can see that there's a decrease here in the recall of these positive words when people are depressed compared to healthy. But again, here is the effect after this antidepressant drug dose. You can see that the memory for positive items has increased compared to placebo. So it suggests that there are early effects of antidepressants, that they can increase the processing, the recognition and memory for positive emotional information in a way which would be expected to reverse this important maintaining factor in depression. And actually, this has emerged as an effect which is seen across a number of different antidepressant drug classes. So here you can see the results from 3 separate studies looking at different antidepressants, duloxetine, bupropion, and escitalopram. And this shows the accuracy of recognition of the happy faces, but across the different morphed intensity levels. And so you can see here that you can recognize more happy faces as the intensity of the face increases. That's what you'd expect. But with the antidepressant, this recognition curve is shifted to the left, which means that you, in effect, you need a lower level of happy intensity in the face to be able to correctly recognize it, suggesting a greater sensitivity to these positive stimuli. And so it suggests that this may be a common effect of different types of antidepressant, which may contribute to their therapeutic effects. And so if they do contribute to their therapeutic effects, we would expect that these early changes in emotional processing would be associated with later clinical changes in mood. We know that there's a lot of variability between individuals who take antidepressants, and there's no established way of predicting the likely response rate. And so again, this is one of the first studies to look at this question. In this study, we gave citalopram or reboxetine for 6 weeks to patients diagnosed with depression. And we were interested in the therapeutic response at 6 weeks, defined here as improvement in symptoms. And what we were interested in is whether this was associated with an early change in recognition of happy faces seen within the first 2 weeks. And we found that it was, as you can see in this scatter plot, that is that in those patients that tended to get better from depression with the antidepressant treatment, they were more likely to have a greater shift in processing of these positive, happy facial expressions of emotion early on in treatment. So very consistent with the idea that this could be a mechanism by which these antidepressants are working. And it explains a reasonable proportion of the variance, although obviously not all of the outcome in terms of depression. More recent work has used machine learning to form a classifier to classify individual patients as being likely or not likely to respond to an antidepressant drug treatment. This is work led by Mike Browning. And this is particularly important if we're going to use these kinds of changes in a clinical context. A correlation is useful for our science. It suggests that these two processes might be related, but at the end of the day, you have to use this information to make a decision about, for example, whether to adjust someone's medication or not. And so this study recruited patients who come into primary care with depression, and they're just prescribed an SSRI with citalopram, and they took part in this emotional processing test at baseline before they started the treatment, and then again after 1 week. And then this machine learning classifier, based on this response, was set up to indicate whether the patient was likely to respond or not to respond to that antidepressant. And so you can see the figures here. So the machine learning classifier predicted that 34 specific patients would not respond to the antidepressant, and this was true for 28 of them. And it predicted that there would be a clinical response in specifically 23 of these patients, and this was correct for 16 of them. So overall, it was correct in 77% of cases. So it's above chance, suggesting that this may be a useful marker of clinical non-response. I'll come back to this a little bit later about how we try to use this in a clinical context. This association between early change in emotional bias and the clinical outcome has been replicated across different groups. This is a paper from Sharoma looking at the influence of early change in facial expression recognition in those given citalopram with late life depression. And I mentioned this paper because it suggested a particular role for the environment, which I think is important to consider when we're thinking about antidepressant drug action. So here you can see the change in the depression score with the Hamilton Depression Rating Scale across the 8 weeks treatment with citalopram. They measured facial expression recognition again before treatment and after 1 week, and then they used this to divide up patients into whether they showed an early improvement in emotional bias or not. And you can see the group here in light blue who didn't show an improvement in positive bias early on in treatment. And you can see that they really don't show a very good therapeutic response to citalopram. But the group who did show this early improvement in positive bias, seen here at day 7, before therapeutic effects kick in, they did go on then and show the therapeutic response. So it's very consistent with the other data that I've shown you so far. But this paper also highlighted a particular role or a potential role for the environment in moderating this effect. And this is predicted by the model that I started with. So if we go back to the model, we've suggested that it's change in emotional bias and how we deal with emotional information situations that would lead to improved mood. But critically, this would depend on a period of exposure and learning and response to the environment around them. And so you could imagine that there may be situations in which this translation is not always straightforward. So, for example, we know that many people with depression have become isolated, meaning that there may be less opportunities to learn from their environment, or they may be in a particularly difficult or toxic environment, which means that this quite subtle change in emotional processing may not be enough to counter this particular environmental input. And they found some evidence for a role of this environment in patients receiving citalopram. And they did this by looking at the level of social support that patients rated themselves as having. So this is shown on the x-axis here. A higher level means a higher level of social support. Here you can see the recovery from depression, decrease in the Hamilton Depression Rating Scale by the end of treatment. And you can see this relationship between these two factors in the group, first of all, who have no improvement in positive bias. And you can see here, it doesn't really matter how much social support you have, there's no real therapeutic response. This line is pretty flat. But in those patients who do show an early improvement in positive bias, this seems to be particularly beneficial when it's coupled with a supportive environment, suggesting that when we think about antidepressant drug action, we can't just think about the psychopharmacology of the drugs, we can't just think about the cognitive effects, we also need to think about how they may interact very specifically with that individual's own environment. So overall then, so far, we've seen that antidepressants do affect how emotional information is processed, that they do so very early on in treatment before there are changes in mood, and are associated with these later changes in mood. And it may be particularly important to consider the involvement of the environment in moderating these kinds of effects. And so our next question was whether we could use this kind of emotional processing framework to understand the neural effects of antidepressant drug treatment. There's been a lot of work looking at the underlying neural correlates of negative affective bias in depression. Here are a few reviews collating this evidence. But much of this evidence suggests or supports the idea that there's an imbalance in frontal limbic circuitry in depression. In particular, what we tend to see is an exaggerated response in areas like the amygdala to negative affective stimuli, the amygdala being very important in attention and vigilance to salient stimuli in the environment. And then this is often coupled with under-engagement of areas which involved more in regulation or inhibition or contextualization, such as the dorsolateral prefrontal cortex and the medial prefrontal cortex. So the suggestion is that there's either too much bottom-up signal or not enough top-down control, or a combination of the two in depression. There's also evidence that different types of treatment for depression can impinge or affect, modulate this underlying frontal limbic circuitry. This is the results of a meta-analysis synthesis that was conducted by Camilla Nord and colleagues in Cambridge. And they took meta-analyses of the effects of antidepressants on emotional processing circuitry, and also a meta-analysis on the effects of psychological treatment on this same circuitry, and collated and compared these results. And they found that both these treatments did impinge on this frontal limbic circuitry, but they seem to do so in a different way. And so antidepressants in particular seem to reduce this amygdala response to negative stimuli, the bottom-up signals of this circuitry, whereas psychotherapy seemed to particularly affect the medial prefrontal cortex response, more of the top-down control of this circuitry. So the end product might be the same, but it looks like these are coming in at slightly different loci within this system. We do have to bear in mind, though, that the papers themselves very rarely directly compared psychotherapy and antidepressants, and there are slightly different traditions in how these fMRI studies were conducted in the two fields. And so there's quite a lot of differences between the kinds of paradigms that are used, and also the length of treatment which goes into these comparisons. So I think it's very consistent with both similarities and differences between these kinds of interventions, but we do need more head-to-head comparisons of these treatments to take this field forward. And a lot of the studies that were included in the meta-analysis tended to look at the effects of antidepressants given over quite prolonged periods of time, certainly once the therapeutic effects have kicked in. And when we do this, it's very difficult to disentangle cause and effect. Are the effects on the amygdala, for example, because the drug has had a direct effect on the amygdala, leading to the therapeutic change? Or is it that the drug is having some other effect, but once patients feel better and they go into the scanner feeling less depressed, the amygdala is less activated? And so again, we were very interested in whether we could see these kinds of effects early on in treatment. And this is work with Beata Godliska. And so in this study, we recruited depressed patients and we randomized them to receive 1 week's treatment with either placebo or escitalopram. And we also compared them to healthy controls. And we used a very simple fMRI paradigm with just positive and negative facial expressions of emotion. And so here you can see the effect of depression in response to these kinds of fearful faces or happy faces. And this is the response in the amygdala. And you can see that, consistent with previous work, when people are depressed, they tend to show this kind of overactivation of the amygdala to these negative stimuli, which is not seen in response to the positive stimuli. So this is consistent with these negative stimuli being more salient or more attention grabbing in the depressed patients. But this is what happens with 1 week's treatment with an SSRI, in this case escitalopram. And you can see this response in the placebo group has been reduced, actually back down to near normal levels following this escitalopram treatment. These patients didn't feel any different at this early time period. There was no difference, for example, in the BDI or the Hamilton Depression Rating Scale between these two groups at this 7-day treatment period, suggesting that these effects on the amygdala may be one of the first effects to kick in before the therapeutic change. And so again, we can ask whether these effects are more prominent in those patients who are going to go on and respond to the antidepressant drug treatment. So we performed another fMRI study where we recruited depressed patients, and we gave them escitalopram for six weeks. And this allowed us to see whether they were responding or not to the antidepressant based on at least a 50% reduction in symptoms. And what we were interested in here is whether the neural response to these emotional stimuli after 1 week compared to their baseline before they started treatment was different in responders versus non-responders. And we found that it was. All the patients in this study are taking the antidepressant. So we're not looking at the difference between antidepressant or not. We're looking at the difference between later response or non-response. And you can see that there are differences across a whole network of areas which are involved in emotional processing, including the amygdala, including the anterior cingulate, including the thalamus and insula. And the direction of the effects is shown here in the graph for the amygdala, but it was very similar across this network. And that is that it's really only the responders, the later responders, that show this early reduction in response to the negative versus the positive stimuli. And the non-responders, even though they're taking the antidepressant, there isn't this same profile. So again, it suggests that what happens early with antidepressant drug treatment in terms of the neural processing of emotional information may be very important to setting the foundation for the later clinical response. And so when I started off this presentation, I mentioned that a lot of these ideas and work really came from the psychological literature, looking at the psychological maintaining factors in depression. But it remains an ongoing question how and when psychological treatments target these same aspects of rather automatic emotional processing. And there are some data speaking to this, but again, they tend to have been collected at the end of quite extensive amounts of treatment. And so here we were interested in the earlier effects of a psychological intervention on these measures of emotional processing. And we got the opportunity to look at this during the COVID-19 pandemic, where we looked at the effects of behavioural activation given remotely and during our first national lockdown. So behavioural activation is the behavioural part of CBT. It's focused very much on behaviour and using activity scheduling to find the optimum balance of routine, pleasure and necessary activities for that individual. We were interested in two main questions in this study. Is this kind of behavioural activation effective even during this very strange period of restriction, where the opportunity for behavioural change is rather limited? And can we see changes in emotional processing similar to what we'd expect with antidepressant drug treatment? And this is work carried out with Teresa Rosicova and together with Susie Murphy. And so this is the design. We recruited patients with mild to moderate depression for this study, and they were randomized to receive either the behavioural activation treatment over 4 weeks, or they were placed on a waitlist control, although they had all of the same questionnaires and assessments and contact with the experimenters. And we measured the facial expression recognition at baseline after 2 weeks and after 4 weeks. And there was a final follow-up in terms of the clinical measures at 8 weeks. And so in answer to the first question, we found that behavioural activation was effective at reducing depression, anxiety and anhedonia, even during this period of lockdown and the COVID-19 restrictions. You can see here the data for depression, for anhedonia, anxiety, and the behavioural activation questionnaire. And you can see that there's quite clear differences between the groups, which emerge relatively quickly, but are certainly in place by week 4 and and maintained at a follow-up. So it suggests that this is could be a useful a type of intervention. It's relatively low intensity that could be rolled out in these times of difficulty. How about the emotional processing? Well, we found that behavioural activation did reduce the negative bias in emotional processing in quite a similar way to what we saw with antidepressant drug treatments, although possibly occurring a little bit later on in the treatment cascade. And so this is the ability to recognise the negative faces in the face task. This is the change from back to baseline. And you can see that certainly by the week 4 assessment, those in the behavioural activation group here in red are showing a robust decrease in the recognition of negative faces compared to the control. And it turns out that they're actually seeing these negative faces as more positive than negative. And so here on the right, they're more likely to see low levels of these negative faces like anger or disgust or fear, actually as representing more neutral or even positive facial expressions of emotion. And even though there wasn't a group difference at week 2, there was individual differences. There were individual differences that may be relevant, and in particular those that showed the largest decrease in recognition of these negative faces were more likely to show a therapeutic response by week 4. Again, very similar to what we saw with antidepressants. So this suggests that there are at least partially common overlapping effects of different types of treatment, that we can see the effects of these treatments relatively early on in the treatment cascade, and that they're associated with later clinical response. And so in the last few minutes, I would like to talk briefly about the clinical applications of this work so far. And I've listed a few applications that I can think of, and I'm going to go into the last one on this list in a bit more detail. So I think the first one is really about the theoretical perspectives, which may help us design better treatments and particularly treatment combinations. So if we understand how these treatments are working within the same framework, we can think about how to combine psychological and pharmacological treatments, or developing different types of treatments which may target different aspects of this framework. So I think it gives us a model for treatment development. I think it also gives us a potential way of understanding and communicating how treatments may be working with patients, and our feedback from patient advisory groups and from clinicians really across the world has been that patients understand and appreciate this level of explanation. We all know what it's like to misinterpret somebody walking past you without saying hello. We all know what it's like to remember more negative things than positive things, and then perhaps to reevaluate it later. And so it provides a more real world framework to describe the effects of antidepressants than focusing on serotonin or receptors in the brain, which may not be in everyone's vocabulary. It also provides us with a human model that we can use to screen and select new treatments in psychiatry. So we all know that it's very difficult to develop new treatments, and over 90% of new treatments will fail early on in clinical development. And this is largely because of problems with efficacy. And part of the problem is that we don't really have any good way of predicting which treatments are most likely to work. Sometimes they look really good in the preclinical animal models, but then they fail to translate into the clinic. And so perhaps if we can use this as a human model, it might be closer to the experience of depression and provide us with a better prediction of likely clinical action. And this is something that we've worked together with companies and other academic groups to investigate. But I'd like, just in the final few minutes, to focus a bit more on this implication. Could we use these effects, these early changes, as an early predictor of non-response in patients starting SSRI treatment that could be then used to refine the treatment for those individuals going forward, and overall lead to faster resolution of symptoms in depression? And this is something that was tested in the PREDICT trial, which was led by Mike Browning, and with Pivotal. It was quite a large study, over 900 patients across the EU. And this study took part in primary care in patients who had been prescribed an SSRI for depression. And these patients, when they were recruited into the study, they did these facial expression recognition tests and questionnaires at baseline, and then they repeated them a week later, and then again a week after that. And these patients were randomized into two groups. One group, although they did all of these tests, this information wasn't fed back to the treating physician, so it wasn't used to direct their treatment. But in the predicted group, this information was fed back to the treating physician. So if they showed a change in emotional processing, a positive change, this was fed back, this patient is likely to respond, you don't need to do anything, versus this, if they didn't show an improvement, this patient doesn't look like they're responding to this antidepressant, so it may be worth thinking of alternatives. And we figured out that the group who were having their treatment refined on the basis of this emotional processing change may do better overall, and there'll be a higher proportion of responders in terms of depression after the 8 weeks of treatment. But we were also interested in anxiety and in functional recovery. While we were running this study, this important PANDA study was published by Glyn Lewis, and this was a pragmatic trial looking at the effects of an SSRI compared to placebo in primary care, exactly the same kinds of patient groups that we were targeting in our study. And their primary outcome was an effect on the PHQ-9, a measure of depression, which actually didn't show a significant benefit of sertraline. But what they did see quite clearly was an early and sustained effect in terms of anxiety. And so they suggested that in primary care, SSRIs may largely be targeting anxiety rather than depression. And that's very similar to what we saw in our study as well. There wasn't a difference between the groups who had predicted treatment versus treatment as usual in terms of the proportion of patients who responded in terms of depression. But there was a significant difference in terms of anxiety, that there was a benefit in terms of anxiety symptoms in those who had received the predicted treatment. And there was also a benefit in function, which became significant by week 24 of the study. And I think this is really interesting because this is well after the medication is being changed on the basis of the predicted treatment. But it suggests that perhaps if you can target those symptoms really early and really quickly and get the right treatment, you may be able to restore and maintain function. And consistent with this, in a mediation analysis, this change in anxiety at week 8 was found to mediate later changes in function. So I think this suggests it's been a really interesting journey. It was disappointing, of course, that we didn't see changes in the primary outcome, which was depression, but it does suggest that early changes in emotional processing are meaningful, even at an individual level, which is not necessarily the case. It's much easier to see effects at a group level in a lab, and then when you put it into the clinic at the individual patient level, of course, it becomes a lot harder. It suggests that targeting symptoms really quickly may be useful for return to and maintaining function. But it also taught us a lot about how to take something that we developed in the lab and that worked quite well, and then to put it into a clinical outcome. And I won't go into our reflections right now because I know I'm short on time, but I think that there has been a lot that we've learned. And if we were going to do the study again, I think perhaps we may have done it, tweaked a few things in the design. And so just to conclude then, I focused very much on the psychological effects of drug treatments. This may help us understand how these drugs are working and why the effects don't always work for individual patients. There are early effects which may be relevant both for patients and clinicians. It may be wise to consider these different treatments not as the enemy or as competition, but to integrate our understanding and frameworks across different types of treatment. And this may have various clinical applications, from screening new treatments and potentially providing an early marker of non-response that could be used to adjust treatment in patients with depression. And I'd just like to end by thanking everyone in my group, the Psychopharmacology and Emotion Research Lab. This is a sort of familiar scene, I know, to many of us, having our Christmas party on Zoom. And I'd also like to thank specifically the PREDICT team. This was a colossal study with many investigators, and you can see their contribution listed here. So thank you very much.
Thank you, Dr. Hammer. That was a really nice talk and really a lot of good feedback as well. Really appreciate it. And I love the fact how you integrated the research component to the practical clinical component and how we can, translate some of it to our work with patients. So that was wonderful. So they had, let me start with some of the questions that have come across. There was a question about, I think you worked with Guy Goodwin in the past, and they were talking about some of the work that you've done about emotional blunting with the SRIs, and they wanted you to comment, on the time frame, the phenomena, as it seems a little bit different from this antidepressant effect. So, do you want to comment a little bit on that piece?
Yeah, it's a bit of a mystery, the emotional blunting, because it's certainly something which is reported by patients that perhaps responses to both negative and positive information may be decreased. And while that might be useful in terms of reducing the negative, it certainly isn't useful if your positive experiences are blunted. I think that might relate to different neural circuitry and tasks than the ones I presented here. So here, with these kinds of social affective responses, we do tend to see pretty early and pretty positive effects that relate to later therapeutic response. But if we look at reward paradigms and, for example, the ventral striatal function, we actually see something which may be more relevant to blunting, that actually the response within ventral striatal networks and response to reward does actually seem to be a bit blunted with SSRI type medication, at least early on in treatments. And so it seems like there's two, well, probably more than two, but two kind of different processes that we're capturing here. And what was interesting is that sometimes you can see those within the same set of patients. So with one study, we looked at the effect of bupropion, and we found very quick effects in terms of emotional processing, less negative facial expression recognition, more positive memory. At the same time, reward learning was decreased initially, and then it recovered again by week 6. So I think it's complex, and I think that there probably is some blunting of reward systems early on with antidepressants. Whether that's maintained in the longer term, I think is it's a bit unclear from the literature that's published to date. Yes, good question.
Yeah, there's a follow-up question on this. There was a question about, some people are saying the patients say that antidepressants don't make them less depressed or anxious, but they make them more numb or careless about the cause of anxiousness or depression. Any thoughts on that?
Well, I think that it's a really valid and important description of the experience, and I know it's quite common in surveys of people taking antidepressants, that feeling of being blunted and numb. It is really difficult to know from the patient reports if it's, for example, if you're depressed with anhedonia and then you're treating some of the negative aspects, but perhaps not restoring the positive processing sufficiently, that perhaps the overall experience might be one of being blunted. So it may be a combination of untreated symptoms of depression plus the effects of antidepressants. But I think that there is something as well to do with this reward function that that may contribute to those experiences. But I don't think we fully know the answer yet to that. It would be interesting to know, because surveys also, they capture people who are interested and are experiencing those side effects. And what would be really useful to know is more sort of pragmatic sampling, how common those kind of reports of blunting are across many people taking antidepressants.
There's a question about, in terms of research, I was intrigued by the role of the environment that you mentioned, how crucial it was. The question was, in terms of clinical trials, how could this be measured, the understanding the environment's mediating role with antidepressant effects? You want to talk a little bit about that?
Yeah, it's something that we haven't really done very much of ourselves, but I think although I think it's really important and we need to find good ways of measuring the environment. One is to use the same kinds of instruments that Sharoma used, which is the patient's report of how supportive their immediate social circle are, which I think is a reasonably good proxy for that level of social interaction that we think that you need to benefit from these effects of the antidepressant. Other researchers looking at much bigger data sets have tended to use markers of what they think of as environment, so socioeconomic status, relationship status, poverty, which could all kind of feed into the overall environmental experience. So I suppose that's it. But I imagine that there's a lot of that might be it might work in kind of big data sets because there's so much variability within those different categories. So I think probably the studies measuring the patient's perception of their social support would probably be the best.
There was a question about the psychotherapy part. I mean, you had mentioned about behavioral activation as a reference for psychotherapy. The question about, do you see similar effects with the CBT?
We haven't looked at CBT, partly because we needed a quite simple, low intensity type of therapy for this one, and we wanted to kind of look really early on, and the behavioural activation does have quite early effects. There are some other reports that CBT does change these kinds of emotional processing biases in depression, but they as the field, the kind of state of art of the field is that they would measure those after 6 months, for example, when patients are kind of feeling a lot better. And then you don't really know what's driving what, because of course you probably will approach these tasks differently if you're not feeling so negative in terms of your symptoms as well. So yes, a good question. I yet to do it.
Okay. There's a question about subgroups. I mean, if you're looking at subgroups of depression, the question was around atypical depression with rejection sensitivity. The thought was that maybe this effect will be more strong for this subpopulation versus melancholic depression. What are your thoughts on that?
Yeah, we haven't looked at, like many people, we have tried to look at subgroups. I have to say that these studies are probably not large enough to really pull apart different subgroups in that way. We might not really have enough power. But we did, in one study, we did show that the main effect was related to kind of social experience and social rejection, that the effects seemed to particularly be associated with the therapeutic effect. So I think it's an interesting hypothesis that that should be looked at. We probably need to collapse across a number of studies to really get the power to look at that subgroup grouping, but I think it is a good place to start.
Okay. There was a question about this aspect about cognitive bias and how it mediates change in depression. Or does a relationship mediated by changes with anxiety? I mean, the question is, does it start with changes in anxiety, and how does that tell us about the pathway to depression? You know, is it changes with the anxiety pathway that leads to depression? Any thoughts on that?
Yeah, they're so overlapping, aren't they? It's really difficult to pull it apart. We have usually used depression as the outcome measure that we're looking to predict, just because that was the way that we were thinking. We didn't have the results of the PANDA trial to even really think about anxiety. But within that, within any measure of depression, there will be some symptoms of anxiety, and of course, many patients will have comorbid anxiety that were included in the study. The only time I can think that we looked at that really specifically was in the imaging paradigm, the prediction there. And then we looked at changes in state anxiety, and we didn't, we could control for the differences in state anxiety, and it didn't affect the association with depression. So we were quite convinced actually that it was a direct effect on the affective components underlying depression. But now we see the results of the PANDA study and the PREDICT study suggest that the experience may relate more to anxiety. And so, yeah, we need to do more work on that as well.
So there's a question here about if someone does not demonstrate any early changes in emotional processing, does that imply they don't respond to specific antidepressant, or is there any prediction that they don't respond to antidepressants in general?
Yeah, probably not, because in the PREDICT study, the change was usually to another SSRI. And so all we can say is that it's a marker of that person responding to that specific treatment at that dose in that specific setting. And so it might be, and I think that's both its value and its problem in a way, because obviously it's more problematic in a clinical clinical setting to measure things twice rather than have a kind of baseline predictor. It might be more useful, but I think that's much harder, because basically you're saying that this person their brain is doing the right thing. They've got the first part of the response to this antidepressant. Therefore, the likelihood is that given the right circumstances, they will go on and respond. But if we even change to another antidepressant, we know, for example, from the STAR-D data, that the likelihood of responding to the second SSRI is not any less than the first trial, really. And so I don't think we can say anything fundamentally that this person's not going to respond to an SSRI. They're not responding at that time, at that moment, to that dose in that setting, which might be the closest to the prediction that we can get.
Okay. There was a question about, is there any experience with stimulants and only response to cognitive bias?
We have looked at drugs like amphetamine, for example, and they just make people a bit more sort of faster, kind of a bit more jumpy. They surprisingly didn't seem to really increase the cognitive bias. But of course, there is a lot of interest in other treatments that can have faster onsets of action, such as ketamine or psilocybin. And we are really interested in those questions. And we've actually started studies looking at that, both in terms of these kinds of measures of emotional processing, but also perhaps these other measures that might not be very well served by antidepressants in general, the SSRI type of antidepressants, such as the reward function, which may be a kind of missing component of those kinds of antidepressants, but may not be with the drugs that can work much faster. Yeah, it's interesting.
Any studies on pregnant or postnatal individuals? Are the changes similar?
There's certainly work suggesting that you can see the negative biases in individuals with postnatal depression, but actually we haven't looked at it with this kind of treatment paradigm. Yeah, you're all giving me lots of ideas for the next 20 years of my career.
Maybe one last question and that'll be it. There's a question on facial recognition and prediction of response in depression in adolescents. Any thoughts on that?
Yeah, we just started some work in adolescent depression. Obviously, it's much more challenging to do studies in adolescents with antidepressant treatments, and whereas a lot of what we've done in adults, we worked up in healthy people first, and then we translated it into depressed patients, which is much more challenging in adolescents. But we did run a study in depressed adolescents that were just about to start fluoxetine, and we measured their bias before and then 6 hours later after their very first dose, or placebo. We were able to use a placebo. And what we found was that there were early effects in emotional bias in adolescents as well, but they tended to focus more on the response to anger, which is really interesting given the central role of irritability in adolescents with depression. So I think that there are effects of antidepressants on broadly similar mechanisms of emotional processing in young people, but we need really much more work to try and get the right paradigms for young people, and to really start again, because we can't assume that it's going to be exactly the same as it is in adults.
Dr. Hammer, thank you. It was a wonderful talk, and there's so many questions. I wish I could get to all of them. I know, please, if people have extra questions, you can contact Paula Panic, and we can maybe send the questions to Dr. Hammer, and she can get back to you on that. I apologize. Thank you, everyone, for being here. I would just like to just share the screen again. Thank you to Oxford as well for this wonderful collaboration. We've learned so much. And maybe this is a good segue to our next grand rounds. It will be on child and adolescent from Sick Kids. So join us on March, end of March, for the next set of grand rounds. Once again, thank you, everyone. Sincere appreciation. Take care. All the best.
Thank you very much.
Yeah. Thank you.